Bismillah ar-Rahman ar-Rahim. Urodynamic at a glance. I am Dr. Hamdy Abdalhady, pelvic floor reconstructive surgery and urogynecology consultant, urogynecology unit at Ain Shams University. Lower urinary tract symptoms are common in women of all ages. These symptoms may include wetting herself, incontinence, needing to pass urine frequently, or discomfort passing urine. Stress urinary incontinence and overactive bladder are highly prevalent conditions in females, and these conditions may require urodynamic evaluation. So, urodynamic can be a riddle for physicians to solve. Objectives of this presentation is to enable physicians to solve this riddle and make it easy for them to interpret the results of this investigation, how to implement this data. In order to do so, we have to answer a few questions first. These questions are: what is simply urodynamic? Who needs urodynamic? What to look for in the report? And how to use the data given. If you answer these four questions, you will be able to read the urodynamic report easily. So our first question is, what is simply urodynamic? Urodynamic studies are the studies that is done to assess the function of the bladder. We have two main functions of the bladder. The first one is storage function. It is assessed by bladder filling and urethral closure. And the other function of the bladder is to evacuate urine, or bladder emptying. So we have two functions to assess. Number one is bladder, the ability of the bladder to store urine, and the ability of the bladder to evacuate urine. This is achieved by filling the bladder with water, then emptying it again, while measuring the pressure within the bladder, urethra, and abdominal cavity. This is our urodynamic machine at Ain Shams University Urogynecology unit. This is the main unit. This is the pressure manometers. They are water-filled manometers. This is the commode with spinning disc underneath it, connected by a wire to the main unit, a cable, wire cable, and this is a specially made table for the urodynamic test. So we mentioned what is urodynamic. It's just simply filling and evacuating the bladder while measuring the pressure inside the bladder and the urethra. So who needs urodynamic? Urodynamic is an invasive test. So conservative, empiric, non-invasive treatment of lower urinary tract symptoms without urodynamic is an appropriate practice, AUA 2012. In females, symptoms associated with the storage of urine are more prevalent than symptoms associated with voiding. So in gynecological practice, we have these three common diagnoses: stress urinary incontinence, overactive bladder, and mixed urinary incontinence. Mix of these two findings are the most common types of urinary incontinence in female. So urinary incontinence in female is more prevalent than urinary retention and other voiding difficulties. Who needs urodynamic? First, overactive bladder and mixed urinary incontinence. If a patient presented to your clinic, your gynecology clinic, with frequency, urgency, incontinence, don't rush to ask for urodynamic study. Wait. First, exclude urinary tract infection. Perform pelvic ultrasound to exclude, for example, if patient having fibroid uterus or cervical fibroid, it may cause pressure on the bladder, mimicking the symptoms of the overactive bladder. Okay, and measure post-void residual volume. It's a very easy test. You just tell the patient to go to the bathroom and evacuate her bladder. Then, using transvaginal ultrasound, you can assess the residual urine volume. Treat urinary tract infection if present. If you have urinary tract infection, treat it. Control diabetes if the patient is diabetic. This is a lady with severe urgency. So, after treating urinary tract infection, controlling diabetes, rolling out other factors, for example, fibroid completing the bladder stone, then you can start with drug therapy, for example, anticholinergic drugs or the new beta-3 agonist drug. When medical therapy fails, and surgical management is required, for example, prolapse surgery, then perform urodynamics. So before going to urodynamic, if a patient came to your clinic complaining of frequency, urgency, nocturia, if there is no pathology present, if there is no urinary tract infection, nothing, you excluded everything that causes the symptoms, then you can start anticholinergic drugs or beta-3 agonists if they are not contraindicated. Okay, so you can start with the anticholinergic drug. The most famous one now is sulfasalazine. Okay, or the beta-3 agonists like mirabegron. You can start anticholinergic therapy or beta-3 agonist therapy for at least 1 to 2 months. If the patient improved, even mild improvement, you can go on with the treatment. No need for urodynamic. But if medical therapy failed, you already started anticholinergic, you increase the dose to the maximum dose, you change it to beta-3 agonist, still no improvement, or the patient is going to have surgery for prolapse, then urodynamic is indicated before performing this surgery. Stress urinary incontinence. In case of symptomatic pure stress urinary incontinence with no symptoms or signs of voiding difficulties and without relevant post-void residual urine, advise the patient to start pelvic floor muscle training without urodynamic study. Patient refusing or not fit for surgical management for any reason also do not need urodynamic study. For example, patient taking something like Marivan or for treatment of DVT, patient with history of stroke, patient has any contraindication for surgery, and she's complaining of stress incontinence. She will not benefit from urodynamic. It will be an invasive test without need. This is stress incontinence. The patient is coughing, as we can see here, and urine is leaking drops out of the bladder. So the second is stress urinary incontinence. So urodynamic is indicated in stress urinary incontinence when surgery is considered in high-grade pelvic organ prolapse without stress incontinence to assess for occult stress incontinence. What do you mean by these two indications? This is the only two indications of stress incontinence. When surgery is considered, if patient came to you and you already started with her the pelvic floor muscle training, and she received also, for example, local estrogen cream, and the patient is not improving, and you are considering an anti-incontinence surgery. So before performing this surgery, you have to perform urodynamic first. Also is when women with high-grade pelvic organ prolapse. If you have a patient, for example, with complete procedentia or stage 4 POPQ cystocele or uterine prolapse, and you are going to perform surgery for this lady, so you have to assess for occult stress incontinence before performing this surgery, as this prolapsed vagina and the bladder may cause kink of the urethra and hiding or keeping the stress incontinence hidden. Then when you reduce this prolapse, the occult stress incontinence reappear and the patient will come complaining to you of urinary incontinence. So these are the only two indications. Although some societies, for example, the Royal College of Obstetrics and Gynecology, they recommend to have surgery without going to urodynamic first, because some other societies, especially of the International Continence Society and International Urogynecology Association, they recommend not to perform surgery before doing urodynamic first. So if you are going to do anti-incontinence surgery, first you have to do urodynamic, and if you are going to correct a high-grade pelvic prolapse, you have to do urodynamic before performing the surgery. So to summarize the indication of urodynamic, whenever surgical intervention is planned, no surgery without urodynamics. Whenever there are doubts about the pathophysiology or different unrelated complaints, for example, you have a patient with incontinence, urge and frequency, not responding to medical treatment, and you found that the patient is having high post-void residual urine in multiple occasions. If patient is complaining of difficult micturition plus stress incontinence, so any different symptoms of incontinence and voided dysfunction, you have to perform urodynamic before starting treating the patient. And the last one is failed conservative non-invasive therapy. You already gave the patient anticholinergic and it failed. You already gave the patient beta-3 agonist to correct her urgency and frequency and it failed. You already patient started pelvic floor muscle training for a considerable period of time, but still no improvement. So after all the conservative non-invasive management fails, and you may consider shifting for surgical treatment, so perform urodynamic before shifting to this model of treatment. So if you have urodynamic report that already done, this report you'll find a lot of numbers, graphs, and you don't know what to do with this. What is all these numbers, and what these graphs and these drawings mean? Even if you have a report, you have find a lot of data: reduced bladder capacity, normal compliance, early sensation, stable detrusor, leak detected during cuff, urethral pressure profile, reduced closure pressure at rest, negative closure pressure at stress. How do I make use of this? And I have a diagnosis, yes, mixed type of incontinence. But what is all this data? How I benefit from this data? You see here, this is a cystometry, multiple peaks, patient cuff, then we have a leak here. What is these numbers and how to make use of these numbers? We have here a number, another number here, another number here. Also, you find this in the report, a lot of figures and a lot of data, percent of functional length, bladder stress pressure, transmission pressure, depression, a lot of things. How do I use them, or which item I use and which item I ignore? So first, before knowing what to use, we have to know the normal findings. What is the normal findings in urodynamic report? So the urodynamic parameters of interest for the gynecologist are the following: cystometry, urethral pressure profile, and uroflowmetry. These are the different three tests that we will discuss in this lecture. Okay, cystometry including first desire, maximum cystometric capacity, detrusor, muscle condition, and leak point pressure. Urethral pressure profile will take just one item, maximum urethral closure pressure. Then uroflowmetry, including 4 parameters: maximum flow rate, voided volume, post-void residual volume, and voiding pattern. Okay, we will discuss all these items in the next slides. Okay, we will start by cystometry. What is meant by cystometry? Simply is filling the bladder with normal saline, and we will measure the pressure inside the bladder, the pressure inside the abdominal cavity, and during this filling procedure, and we'll comment on the following. Okay, first of all, we have to know that there is a great inter-center variability in normal figures, which means that different centers all over the walls with different countries have different normal figures, but there is universally accepted figures regarding these parameters. First item is bladder capacity and sensation. First desire, normally it is about above 150 ml, which means that the patient will say, yes, I have a desire now. Her first desire will be around 150 ml or cc. Okay, maximum cystometric capacity. In females, maximum cystometric capacity is around 480 cc, which means that the normal figure is around this number, meaning that if a patient came and urodynamic was done for her, no, it's accepted to have bladder capacity of 450, 460, 470, 500, so it's around 480. In our center, in urogynecology unit, the accepted figure in Egypt, most studies reveal that bladder capacity above 400 cc is accepted as a figure for cystometric capacity. What does this number mean? Means that the patient can accommodate up to 400 cc of urine inside her bladder without leaking. She can accommodate 400 cc of urine inside her bladder and she is continent. Okay, so the number is, the universally accepted number is 480. Around this figure, it's normal. In our center, it is around 400. Below 400 cc means that there is reduced bladder capacity. Okay. In children, the bladder capacity is calculated from the following formula: 30 plus 30 times age. For example, if you have a 5 years old child and you perform urodynamic, you want to know what's the bladder capacity for this child, you will calculate from this formula. About 30 plus 30 times 5, about 150 plus 30 is 180, but the bladder capacity in a 5 years old child is 180 ml or cc. Detrusor muscle condition. Normally, during urodynamic, there is no uninhibited detrusor contraction during filling despite provocation. During we are filling the bladder with saline, there should be no any detrusor contraction. This is a normal finding. So if you find back contraction, what does this mean? This diagnoses what we call an overactive bladder or unstable detrusor. So to diagnose an overactive bladder or unstable detrusor, we have to find one of the following items. So normally, no uninhibited contractions. What is abnormal? The next thing we are going to see now. Detrusor pressure, terminal pressure is more than or equal 15. If you have a curve with detrusor pressure reaching more than 15 centimeter water, this is the diagnosis of overactive bladder. Item number 2 is high amplitude detrusor contraction, also more than 15 centimeter water during filling with or without voiding. Sometimes when filling the bladder with no saline, the patient pressure may increase and she may even lose control and start voiding while you are just filling the bladder. This is what we call wet overactive bladder. Then the third item is multiple low amplitude contraction, which means that increase in the detrusor pressure more than or equal 5 centimeter water from baseline. What does this mean? If you have, for example, you are filling the bladder and your baseline detrusor pressure is 7, okay, 7 centimeter water. Then the patient now told you, doctor, I have a desire now to micturate. And while she's saying that the detrusor pressure increased from 7 to 12, then you stopped filling the bladder. The pressure returned to its baseline, which is 7, for example. So this is what we call a low amplitude contraction associated with desire. If she did not say that I want to or I have a desire to micturate, and this contraction happened in front of you, the pressure increased from, for example, 7 to 12, then returned back, but without desire. This is normal finding during urodynamic study. You might have low amplitude contraction, but if this low amplitude contraction was associated with desired void, it is a diagnosis of overactive bladder. Not associated, this means that it is not an overactive bladder. We will see it later on the graphs. This is a graph you can see here. This is the detrusor curve. It's here. Okay. You see, this is scale is 50 and 100. This is a high amplitude contraction. How did I know that? This peak is around 20. So it is around 20 or more. This means that this is high amplitude contraction, more than 15. Another one, another one. Then this is terminal pressure. What do you mean by terminal pressure? Here the bladder volume is 300 cc mil, and this pressure here is at the end of the test is more than 50. It's about 60 or something like that. In this graph, we don't have the flow curve, but if it's present, you will find that this patient is now voiding, because 75 detrusor pressure is very high. This is voiding. She's voiding right now. Okay. This is what I mean by low amplitude. For example, you see here, this here patient said I have first sensation, and the baseline here is around maybe we say 6 or 5 centimeter water. Then it is elevated up to 11, so it increased about 6.6 from 5 to 11 centimeter water. Okay, the pressure increased here, and during this increase the patient reported, what did she say? I have a first sensation or first desire. This is a low amplitude contraction. This is what I mean by low amplitude detrusor contraction associated with desire. But if the patient did not report desire at this point, this mark is not available. Okay, this means that this is normal finding during the dynamic study. Again, here we look at this is abdominal pressure, vesical pressure. We look at the detrusor pressure. This is scale from 0 to 100. This is around 20 or something. Again, this is high amplitude contraction. Another high amplitude contraction. Then it returns to baseline. So the detrusor can be diagnosed from the curve itself. You see here it's elevated. Normally, this shape should not be present. This is another strong contraction that persisted for a long duration of time. You see here, this is a detrusor pressure. This is 0 to 100. Each point of this represents 20 centimeter water. But this is about 40 up to 50. Then return to around 30 centimeter water. Then after a very long time, it returned to baseline. This is a very strong detrusor contraction. The third item we have in the cystometry is Valsalva leak point pressure. What is Valsalva leak point pressure? It means that you tell the patient to push down against her pelvic floor, or sometimes you tell her to cuff. Then we observe if there is leakage happens, the machine will record this leakage and record the pressure inside the bladder during this leakage. Okay, but what is Valsalva leak point pressure? It is the minimum pressure recorded during cuffing or Valsalva in which leakage of urine happens. It is the minimal recorded pressure. I said it by simply, we tell the patient to push down as if she have constipation or something, or even cough, and once there is a drop of urine gets out of her urethra, the machine will record the pressure inside the bladder during this leakage. There is a great scientist called Maguire in 1996. He classified patients with general stress incontinence into 3 groups according to their preoperative valsalva leak point pressure. So this item, the valsalva leak point pressure, it diagnoses the stress urinary incontinence. Without this item, there is no diagnosis of urodynamic stress urinary incontinence. So if normally, there is no leak point pressure. Continent patient does not leak whatever the pressure inside her bladder. So continent patient does not leak whatever the pressure inside her bladder. Incontinent patient, due to hypermobility or sphincteric deficiency, will leak urine. According to the pressure inside the bladder during this leakage, we classified stress incontinence patients into 3 groups. Okay, we have 3 types of stress urinary incontinence. There is type 1, type 2, and type 3. Okay, type 1 stress urinary incontinence, according to the Maguire classification, which is the best one until nowadays. This is what we call pure urethral hypermobility, where valsalva leak point pressure is more than 90 centimeter water. So if patient started to push down or to cough and her leakage happened when her bladder pressure was equal or more to 90 centimeter water. This means that her sphincter is normal. She has normal urethral sphincter, but the problem is the support. The pubocervical fascia is not supporting the bladder as it should be to compress the urethra against this fascia during coughing, making the patient continent. So if she has hypermobile urethra, the fascia is damaged, but her sphincter is intact. This is what we call type 1 stress urinary incontinence. Her valsalva leak point pressure will be more than 90 centimeter water. Then we have type 3. What is type 3? Type 3 is stress urinary incontinence, is what we call intrinsic sphincter deficiency. What is type 3 stress intrinsic sphincter deficiency? Here, the sphincter itself, the smooth muscle fibers around the urethra, the bladder neck, are damaged due to anything, due to radiation, due to previous surgery, due to trauma, whatever. It's not working. Her sphincter is not working. This patient's sphincter is damaged. So her leak point pressure will be less than 60 centimeter water. What does it mean also? It means that if you tell the patient to push down or to cough, she will leak urine at a pressure less than 60 centimeter water. Okay, when she leaks, you will find the pressure inside less than 60 centimeter water. Then we have type 2. What's type 2? Type 2 is midway in between type 1 and type 3. The leak point pressure is more than 60 centimeter water, but less than 90 centimeter water. Here we have a little bit of this and a little bit of that. What does this mean? We mean we have both urethral hypermobility, an element of urethral hypermobility, plus partial sphincter deficiency or sphincteric weakness. This means that the patient has, for example, her pubocervical fascia is not supporting the urethra as it should be, so the urethra during coughing or during straining is hypermobile, plus the sphincter, the smooth muscle fiber around the urethra itself, is not functioning 100%. It's functioning 50 or 60%, something like that. So there is some sort of weakness in the sphincter, whatever the cause of this weakness, but not completely sphincteric deficiency. If the sphincter is completely deficient, it would give us type 3 with valsalva leak point pressure less than 60. But type 2, there is hypermobility, part hypermobility, and part the sphincter itself is not functioning 100%. So we have three types of stress incontinence according to valsalva leak point pressure. This is important. It will give us hints and leads for the coming slides. Type 1, pure urethral hypermobility, where valsalva leak point pressure is more than 90 centimeter water. Type 3, it is less than 60, where we have intrinsic sphincteric deficiency. And type 2, mixed between both hypermobility and intrinsic sphincteric deficiency, VLPP between 60 and 90 centimeter water. Okay, now we come to the urethral pressure profile. What is meant by the urethral pressure profile, or the maximum urethral closure pressure at rest? We have a lot of figures in the urethral pressure profile. The most important one is the maximum urethral closure pressure. This number is subtraction of the pressure inside the urethra minus the pressure inside the bladder. Meaning, if the pressure inside the urethra measured by the urodynamic machine is around 100 centimeter water, and the pressure inside the bladder is around 7 centimeter water or 10 centimeter water. So when we subtract these two numbers, so 100 minus 10, it will give us 90. So this is what we call the maximum urethral closure pressure. Okay, another example, if the pressure inside the urethra measured by the machine is 115 centimeter water, and the pressure inside the bladder is 15 centimeter water. When we subtract these numbers, 115 minus 15, it will give us the number 100. So the maximum closure pressure is subtraction between two numbers. The first number is the pressure inside the urethra. The second one is the pressure inside the bladder, or the vesical pressure. Now we come to the normal values. Okay, if we have a female around the age of 20 in the reproductive age group, her normal urethral closure pressure is around 90 centimeter water. Okay, then as age advances, this pressure inside the urethra decreases until it reaches 60 centimeter water by age of 50. So at the age of 20, the maximum urethral closure pressure normally is around 90 centimeter water. Then it gradually starts to decrease gradually until the age of 50, where it reaches 60 centimeter water. This is the pressure inside the urethra of a normally functioning urethra. This is inside a normally functioning urethra with normal sphincter. Okay, so if we have the pressure, measured the pressure inside the urethra, and we found that the maximum closure pressure is less than 20 centimeter water, this means that we have an intrinsic sphincteric deficiency or completely damaged sphincter. Okay, so if we have the pressure inside the urethra measured, and we found it more than 20 centimeter water, but less than the normal, than 90 centimeter water at the age of 20, or 60 centimeter water at the age of 50, then we have what we call sphincteric weakness or partially damaged sphincter. So to correlate these findings with the previous slide, we find here that, as I mentioned in the previous slide, what we have how to diagnose intrinsic sphincteric deficiency by Valsalva leak point pressure. Here we find that the Valsalva leak point pressure is less than 60 centimeter water, which is the type 3 urinary incontinence according to Maguire classification. These ladies, or these women with leak point pressure below 60 centimeter water, you will find their closure pressure is less than 20 centimeter water. So in order to diagnose intrinsic sphincteric deficiency, we need one of two items. Either we do Valsalva leak point pressure, and we found that the leak point pressure is less than 60 centimeter water, or we perform urethral pressure profile and measure the maximum urethral closure pressure, and we find that the pressure inside the urethra is less than 20 centimeter water. So to diagnose again maximum urethral, to diagnose intrinsic urethric deficiency, either leak point pressure less than 60 centimeter water, or closure pressure inside the urethra is less than 20 centimeter water. We come to this figure. If it is more than 20 and less than 90 at age of 20 years, or 60 at age of 50 years, this is what we call partial sphincteric damage. This is what we call it type 2, according to Maguire, the previous slide, where we said that type 2 stress urinary incontinence, we have leak point pressure between 60 and 90 centimeter water. Here it's between 20 and 90 in young females, and 20 and 60 in old ladies. Okay. Then we come to the last test, which is uroflowmetry. In uroflowmetry, the most important item is maximum flow rate, which is the amount of urine excreted from the urethra or ejected from the urethra in 1 second. Okay. Normal females should have maximum flow rate around 20 ml per second in a voided volume of around 200 ml over 15 to 20 seconds. Okay. So in order to have a valid uroflowmetry, what do you mean valid uroflowmetry? If a patient have evacuated her bladder and you found that she's just voided 120 ml, no, this is not a valid test. In order for the uroflowmetry to be valid, the patient should at least void 200 cc of urine. Okay, so the first item is maximum flow rate, which, as I explained, it is the amount of urine voided in 1 second, the maximum amount of urine voided per 1 second, or in other words, speed of voiding. Okay, in normal females, which is not complaining of any voiding difficulties or obstruction, the maximum flow rate should be more than or equal 20 ml per second. Okay, and for test to be valid, patient should void at least 200 cc or 200 ml over 15 to 20 seconds. The second item is residual urine in normal females also, which don't have any voiding problems. The residual volume urine should be less than 50 cc. Okay, more than 50 cc means that she has some sort of retention or incomplete voiding. This is the commode. This is the spinning disc or the flow transducer, which calculates the amount of urine voided by the patient. We tell the patient to sit on this commode, and we start by the computer. We start the test, and we tell the patient to start evacuating a bladder. Of course, this is in a private area. The doctor and the nurse is outside the room. Only the patient and the machine is working. And now the modern machines, you control the machine by a Bluetooth away in another room away from the patient. Okay, so the most important thing is to give the patient privacy. especially during voiding, because if you didn't give her enough privacy, she might not be able to void and complete the test. She voids here, and this is a recording of her voiding. This is a normal curve of the flow of the refractory. The pressure increases gradually until it reaches the peak, where we call the max flow rate, then decreases gradually until she completely evacuates her bladder. It is what we call a bell-shaped curve. And this is a bell-shaped curve. This is another example. Here we find this is the patient. This is the normally patient pressure increases gradually until it reaches a peak, but the peak here is around 50 ml per second. She has a very strong contraction in the bladder to evacuate her bladder, then decreases gradually. Okay, this above 50, we have a term for the patient who voids in a very short time with with a high speed of voiding. We call them super voider. Okay, so especially this might happen above 50 especially if the patient is having overactive bladder or something. Okay, she cannot control herself, and once she is on the commode, she starts pushing to evacuate her bladder, so the curve might reach around 50 ml per second or more. Then we come to this curve. This is an important curve. If you did not see the curve or the voiding pattern, and you just got the figure 25 milli per second, you will say, no, this is a normal voiding. Patient, her maximum flow rate is around 25. The normal is above 20. She's 25. She has normal voiding. And when you measure the post-void residual volume, you will find it normal. You will say, no, nothing wrong with this patient. But you did not see the curve. If you've seen the curve, you'll find an abnormality here. You see this? Multiple peaks. Why? Okay. The problem here, this is what we call abdominal pattern or intermittent flow pattern. The other word is abdominal voiding pattern. Here the patient evacuates her bladder with the abdominal straining. Here the patient takes a deep breath, then she pushes down. Then she inhales, so she cannot push anymore. So she take a breath, deep breath, then push again. Then she takes her breath, then she push again. Then she takes her breath, then she push again until she completely evacuates her bladder. And you'll find that there is no positive void residual volume, that her bladder is completely empty. So what's wrong with this patient? She doesn't have any obstruction. How did you know? She has very nice maximum flow rate, it's above 20. Bladder at the end of the test is empty. So she has no obstruction. So why she is doing this interrupted pattern? Here, this gives us a clue that the detrusor muscle is not contracting efficiently. In order for the normal female to evacuate her bladder, she starts first by relaxation of her pelvic floor and relaxing her external sphincter or her urethral sphincter. Then the detrusor contracts efficiently to evacuate the bladder, like here. You see here the detrusor is contracting, then the contraction is decreasing gradually until the bladder is completely empty. But here, her detrusor muscle is not working. She has something wrong with her muscle. It's not working efficiently, or is not contracting at all. So the patient uses the abdominal pressure to squeeze the urine out of her bladder. Okay, so here she pushes down, then her breath, she needs to take time to take her breath. So she relaxes her abdominal muscle to take a deep breath. During this area, or during this time, she relaxes her abdominal muscle to take a deep breath. The urine stops from flowing. Then she pushes again and again and again until she completely evacuates her bladder. So this is what we call an interrupted or abdominal pattern. What's wrong with this pattern or this lady? As I told you, she has something wrong with her detrusor. They are not contracting good or efficiently as they should be. So if this case came to you and she's complaining of stress and incontinence and you're going to perform surgery for her, if you see this urethrometry, don't perform surgery. Why? This patient definitely, most probably, she will get post-operative urinary retention. Why urinary retention? Because the patient after surgery, she will have stitches. She will have, for example, if you did Birch-Kolb suspension, so there is abdominal wound if you did open, or even if you did TOT or TVT, okay, there is pain in the perineum. So if the patient will not be able to strain or to push down because of the pain. It will interrupt her pushing. So she will not be able to void normally. She will not be able to evacuate her bladder and will have post-operative urinary retention. So this interrupted flow pattern is relative contraindication for surgery. Okay, is relative contraindication for surgery. If you have this pattern, preoperative, take care. This case most probably will enter in post-operative urinary retention. Why? Because the pain will inhibit her pushing and straining, and already her detrusor is not functioning well, so she will not be able to void after surgery. Now come to the next part of our discussion. If you have a report, we already knew the normal figures, what to look for in the report. Before going to this, we'll revise what we have discussed. So in cystometry, we look for number one, first desire above 150. This is the first figure. First desire above 150. Number two, cystometric capacity should be around 480. And as I mentioned, accepted in females in Egypt, it's more than 400 is good. Above 400 is accepted. If this is the second figure, the first figure is 150. Second figure 400. Then we come to the detrusor. The figure here is 15. 15. The detrusor pressure should not exceed 15 at any time during the test. Okay, either terminal pressure or high amplitude contraction or low amplitude contractions, as I mentioned earlier. Okay, but this is the third figure. You have 150, 400, 15, and then come to the last thing is Valsalva leak point pressure, and this has another three figures. The first one is 90 centimeter above 90 centimeter water. This is type 1 stress urinary incontinence, where we have hypermobile urethra. Then we have below 60 centimeter water. This is type 3 stress urinary incontinence, where Valsalva leak point pressure is less than 60, and this means intrinsic sphincteric deficiency. And we have then type 2, which is between 60 and 90, and this is partial sphincteric weakness plus hypermobile urethra. Okay, يبقى cystometry 3 figures, then another 3 figures. Okay, then we go to the urethral pressure profile. 2 figures to remember. At the age of 20, the maximum urethral closure pressure is more than or equal 90 centimeter water. At the age of 50, it is the normal maximum closure pressure is more than or equal 60 centimeter water. Okay, and it decreases gradually from the age of 60, from the age of 20 to the age of 50, the pressure inside the urethra. Then we come to another figure, which is 20 centimeter water. If the pressure inside the urethra or the maximum urethral closure pressure is less than 20 centimeter water, this is the diagnosis of intrinsic sphincter deficiency. Okay, so in urethral closure pressure, first figure is 90 centimeter water. This is normal for young age females. Then 60 centimeter water, normal figure for menopausal females. Then less than 20 centimeter water, this is intrinsic sphincter deficiency, whatever the age of the patient. Then we come to the last test, which is the urethrometry. The normal maximum flow rate is more than or equal 20 centimeter water. Okay, and for the test to be valid, it should be more than or equal 20 ml. The patient should void at least, the patient should at least void 200 ml. Okay, so you remember these figures. I said them twice now before going to the next. If you have a urodynamic report, you will have a lot of figures and a lot of numbers. So you, in order to understand or to read this report, you just look for the next item. 6 items only is enough for you to read the report. The first item is the bladder capacity, and as I mentioned earlier, it should be between 400 and 480 cc is accepted. If the maximum closure pressure, maximum cystometric capacity is decreased, for example, is 250 cc, then this female patient will come complaining of frequency and nocturia. Her bladder cannot accommodate normal amounts of urine. It's at around 250. She has full bladder and she'll have to evacuate her bladder. Okay, she will complain of frequency. She'll have to go to the bathroom frequently, and nocturia, two or more voids per night. The commonest cause for such condition is the overactive bladder. If the patient having the Truser overactivity or the overactive bladder, then she will have full bladder at earlier bladder volume, not around the normal figure. And also, other cause is severe stress urinary incontinence. This is a little bit tricky. If you have a patient with intrinsic sphincteric deficiency, this means that the pressure inside the urethra is less than 20 centimeter water. So, at very low bladder volumes, around 100, 150, or even as much as 200, the sphincter cannot maintain the urine inside the bladder. So, because the sphincter is damaged, the patient will leak urine earlier. So she have to go to the bathroom to evacuate the bladder completely to avoid having this severe stress incontinence. So the patient will get used to evacuate her bladder earlier. So at earlier bladder volume, at 100, 150 cc or something like that. So that by time the bladder capacity will decrease. So the two main causes for decreasing bladder capacity in females is overactive bladder, and the other thing is severe stress urinary incontinence that lasted for long duration of time, not for not 2 months, 3 months, no, years. Okay, in case if you have urodynamic stress urinary incontinence, this patient is having severe stress urinary incontinence and ISD, and when you perform urodynamic, you diagnose the urodynamic stress urinary incontinence. So you have to instruct the patient to start bladder training, and you prescribe for her anticholinergic. If you performed an anti-incontinence surgery, for example, TOT or TVT, for such cases, okay, then the patient will come complaining of still she's having frequency and urgency. You do not treat her condition. Yes, you treated the stress incontinence, but the frequency and urgency still present. So you have to tell the patient to first to train her bladder, and you prescribe for her anticholinergic after surgery to improve her urgency and frequency condition. So the first item to look for is bladder capacity, and we gave an example how to use the number. Okay, you have 400 to 480. This is a normal, but this is the first item to look for. Second item is the Diffuser. We all remember that the Diffuser pressure should not exceed 15 centimeter water during filling cystometry. So if the pressure increased over 15 centimeter water, then we have what we call a case of overactive bladder. This is the second figure. The first one is bladder capacity. Second is the Diffuser pressure. Third item to look for, the first one, as we mentioned, is bladder capacity. The second is the Diffuser pressure. The third is maximum urethral closure pressure. And we mentioned earlier, normal and pathological values of urethral pressure are overlapping and affected by age. Maximum urethral closure pressure, as we mentioned in the previous slides, incontinent females is at around age of 20, is around 90 centimeter water. Then it decreases gradually, reaching 60 centimeter water by the age of 50. Less than 20 centimeter water indicates intrinsic sphincteric deficiency or ISD. We already discussed it in details in the previous slides. But this is a third number to look for. The fourth is the Valsalva leak point pressure. We already also discussed it before. Normally, patients don't leak, so normally there is no leak point pressure. Continent female do not leak at any bladder volumes or any bladder pressure. But if the patient leaked, as we mentioned, is Valsalva leak point pressure is under or below 60 centimeter water, this is diagnosis of intrinsic sphincteric deficiency or ISD. Over 90, this is type 3 stress urinary incontinence, according to Maguire classification. Valsalva leak point pressure over 90 centimeter water is hypermobile urethra. We already mentioned that. And between 60 and 90, this is a gray area where hypermobility and ISD usually coexist. This is a normal bladder, full, and here when the patient coughed, the sphincter is closed and the urethra is closed. When the patient coughed, the pressure inside the bladder opened the urethra and leakage happened. This is when this leak happens, we measure the pressure inside the bladder, and this is a Valsalva leak point pressure. The fifth item is maximum flow rate, and we mentioned also earlier it should be more than or equal 20 ml per second to perform anti-incontinence surgery. If this number is less than 20 ml per second, then take in mind that there is high possibility of post-operative voiding dysfunction or even urinary retention. We give an example and we should show the graph before. It should be around 20 ml per second, the maximum flow rate. Then the last one is poised to void residual volume. Incontinent and normal voiding pattern in females, the post-void residual volume should be less than 50 ml. If increased, also take in mind that there is high possibility of post-operative voiding dysfunction. But these are the 6 items. This is the last one to look for in the report. Now we come to using the numbers. What do we make use of the numbers? And mentioned earlier, the previous 2 slides, bladder capacity between 400 and 480. If decreased, then start bladder training and start anticholinergic or even beta-3 agonist. The Diffuser pressure reaching 15 centimeter water. This is diagnosis of overactive bladder. Then you can start anticholinergic or beta-3 agonist. Then we come to the maximum urethral closure pressure and Valsalva leak point pressure. We usually use these 2 numbers together, the maximum closure pressure and the Valsalva leak point pressure. If Valsalva leak point pressure less than 60. What does this mean? This means that we have an ISD plus or minus maximum urethral closure pressure less than 20. These are the two parameters to diagnose intrinsic sphincteric deficiency. Then we have an ISD. Then you want to treat this patient. What do you do for this patient? You can go for TVT or injectable bulking agent or pubovaginal sling. So if we have leak point pressure less than 60 centimeter water, or max plus or minus maximum urethral closure pressure less than 20 centimeter water, we diagnose ISD, intrinsic sphincteric deficiency. Then this patient will benefit from TVT or injectable bulking agent or pubovaginal sling. TVT gives better result and low recurrence rate than TOT. TOT is not indicated in ISD. TOT is not preferred in intrinsic sphincteric deficiency. But TVT, you can do it. Birch curb suspension is not indicated in ISD also. So in intrinsic sphincteric deficiency, you have these three options: TVT, injectable bulking agent, or pubovaginal sling. It's better to avoid TOT and Birch curb suspension, high failure rate. Then, if Valsalva leak point pressure between 60 and 90, this is a gray area we spoke about before earlier, and maximum closure pressure more than 20, this means that we have partial sphincteric weakness plus hypermobility. Then, this is a gray zone, as I mentioned. It's better you can go for TVT and TOT. Both are equal. You can treat the patient with tension-free vaginal tape, retropubic approach, or transobturator tape, the transobturator approach. Okay. TVT equal TOT as an outcome, and TVT is better than Birch. So if you are in the gray zone, that means that patient is having partial sphincteric weakness plus hypermobile urethra. TVT and TOT is very effective in such conditions, and it's better to avoid Birch because TVT is better than Birch in such cases. Then if we have Valsalva leak point pressure more than 90 centimeter water plus normal maximum urethral closure for age, okay, then we have pure urethral hypermobility. Pure urethral hypermobility. You can perform TVT, TOT, or Birch. Okay, but if you have type 1 stress urinary incontinence, according to McGuire, where Valsalva leak point pressure more than 90 centimeter water, which this means that we have pure urethral hypermobility. In such condition, TVT can be done, TOT is effective, or even Birch curb suspension also is effective. So in this category, or type 1 stress urinary incontinence, any of the three types of commonest anti-incontinence surgery performed nowadays, you can perform any of them. So it is clear here that TVT can be used in the three types of stress urinary incontinence, in type 1, type 2, and type 3. TVT can be used in the three types. TVT and TOT can be used in type 1 and type 2. TOT can be used in type 1 and type 2. Birch is better to be used in type 1 only. When trying to tailor the proper management for patients with pelvic floor disorder, either pelvic organ prolapse or urinary incontinence, Urodynamic can give you a useful tool for making the right choice. Urodynamic can answer an important question: which operation for which patient? It rings the bell when there is a risk of postoperative retention or voiding dysfunction. Now we come to the last part of our lecture. We will speak about the examples. We given examples for the urodynamic report and show you how to read the report. A 32 years old female, gravida 3, para 3, all vaginal deliveries. All the deliveries were at hospital, no history of prolonged or traumatic labor. Presented to the gynecology clinic complaining of leakage of urine since her last delivery. Leaking happens during jogging and during sexual intercourse during penis introduction. Clinical examination revealed positive stress test. Urine analysis was free. She was scheduled for urodynamic study after failure of conservative management. She already started pelvic floor muscle training that did not relieve her condition. Then she was scheduled for urodynamic. Type. Remember, we are looking for following items. First desire. Here is the first desire. This is first desire to void. It's 112. So the first desire here is early or reduced. It should be more than or equal 150. Here it's 112. Okay. Bladder capacity is 344. Also, we have reduced bladder capacity. Yeah, so in our comment, we have early first desire, then reduced maximum systematic capacity. The third thing we look for is the detrusor pressure. You will find here, this is the abdominal, this is the vesicle, and this is the detrusor. The most important curve to look for is the detrusor. Here we can look at the detrusor curve. You can see it's flat. There is no contractions. So we don't have an overactive bladder. But this is a stable detrusor. You see from the start of the test. Okay, flat. This is cuffing. This is artifact. Okay, the contraction will be like that. It goes up then goes down. But this is artifact from cuffing. Okay, then we go until the end of the test. So we don't have any contraction. So the detrusor is normal. There is no overactive bladder. يبقى first desire here 112 cc, systematic capacity 344. Then we look for the detrusor curve. We see it here, stable detrusor. Then we look for the leak point pressure. This is the leak point pressure. And this mark means that the patient leaked during cuffing. This is a strong cuff, and here the patient, this mark means that the patient leaked during cuff. Okay. The pressure inside the bladder, the vesical pressure, during cuff was 102 centimeter water. The device or the machine already printed the number here. Okay. What does this mean? This means that the patient having her leak point pressure is 102. This is according to Maguire, which type of stress urinary incontinence? Type 1, where the Valsalva leak point pressure is more than 90 centimeter water. Okay. Again, this is first desire, systematic capacity. We look at the detrusor curve. This is the most important curve, the detrusor curve. Then, if there is leakage, we see the bladder pressure during this leakage. Okay, then here we use this cystometry with leak point pressure. Then, this is the table. Okay, first thing to look at the table is the detrusor pressure. Here, this PDET means detrusor pressure. The maximum recorded number is what? 4 centimeter water. To diagnose overactive bladder, we need this number to be 15. So we don't have 15 here. So we don't have overactive bladder. So this is a stable bladder. Okay. Then the volumes. First desire to void is 112. This is early first desire. Why early? Because the normal is at 150. Okay. Maximum systometric capacity 344. Reduced capacity. We mentioned earlier that the bladder capacity should be between 400 and 480. So from this table, we have a stable detrusor, early bladder, first desire, and reduced bladder capacity. You don't need to look at the vesical pressure and the abdominal pressure. It's not of any use here. This is cuff leak point pressure. It was done at bladder volume 293, and the patient was sitting. Yes, there is something I forgot to mention to you. Leak point pressure is done at around 300 cc urine inside the bladder. Okay. The maneuver was cuffing. Leak detected, yes, patient leaked. Vasaca pressure at leakage was 102 centimeter water. Okay, we already got this figure out, figured this number from the curve we have seen before. Okay, but from this table, patient is urine cuff, leak was detected, and the vasaca pressure was 102. This means that the patient is having urodynamic stress urinary incontinence. Her diagnosis is urodynamic stress urinary incontinence. Leak point pressure is 102, which is type 1 Maguire or type 1 stress urinary incontinence. Then we come to this table. This is the resting urethral pressure profile. We performed for this patient urethral pressure profile. The most important item here is the maximum closure pressure. Don't look for the other numbers, just this maximum closure pressure. Okay, here it is what, 95. She's 32 years old, and as we mentioned, the normal for female in the reproductive age group is more than or equal 90 centimeter water. So her sphincter is intact. Her sphincter is intact, and this is typical with type 1 stress urinary incontinence, where the sphincter is intact, but there is the problem is with the urethral hypermobility. The fascial support is not functioning good, or the pubocervical fascia is not supporting the bladder and the bladder neck. So we have hypermobility and stress urinary incontinence, and the sphincter is working properly. This is not an ICD. Okay. Your comment. First, the first graph was filling cystometry and urethral pressure profile. We have reduced bladder capacity. Early first sensation, bladder capacity was 340, and early first sensation was 112. Leak detecting during coughing, stable detrusor, maximum closure pressure 95 centimeter water. Our diagnosis is urodynamic stress urinary incontinence. And if you were asked what to do for this patient, she's already started pelvic floor muscle training that did not relieve her condition. So type 1 stress urinary incontinence, you can do Birch, you can do TVT, you can do D2T, whatever you like. Then we come here, another case, another example, 54 years old female, gravida 2, para 2, all vaginal deliveries, menopausal for 8 years. Menopausal, this is important. Presented to the gynecology clinic complaining of frequency, urgency, and nocturia for 10 years. She has been suffering for 10 years from frequency and urgency. She gave history of using local vaginal estrogen cream for the last 1 year. She was also prescribed sulfenacine tablet for the last 6 months, which did not improve her symptom. She received anticholinergic and she received local vaginal estrogen cream. Urinalysis was free. She was scheduled for urodynamic. So the anticholinergic failed to relieve her condition, plus the local estrogen cream. In any menopausal female, if she has urogenital atrophy which is evident and she's complaining of such condition, local estrogen cream is magic. Sometimes the patient is completely cured from just using vaginal estrogen. This is urodynamic. Okay. First here, we'll look for the volumes as we used to do. First sensation, first desire is around 100 cc. Okay, this is first sensation, first desire, 100 cc. This is earlier. It should be around 150. No, it's 100. Then we come here to cystometric capacity. Maximum cystometric capacity 363. Also reduced. It should be around 400. Then we come to leakage. Did any look at the base of the graph? Does it record any leakage? No, there's no leakage. Then we look here at cuff leak point pressure. The patient coughed repeatedly multiple time at bladder 300 volume was 325. No leakage happened at this graph. Okay, then we come to the most important curve, the Diffuser curve. As I mentioned, we have to look for the Diffuser curve. Here, this is the scale from 0 to 100. The pressure is increasing gradually until here. Oh my God, the pressure here is reaching around 50 centimeter water or more. We mentioned earlier to diagnose overactive bladder, the pressure should be more than or equal 15. No, here is 40 or 50. You see, this is very strong detrusor contraction, very strong. That persisted for longer duration, for more than 1 minute. Okay, for more than 1.5 minutes or something. Okay, so we have here strong detrusor contraction. So what's your diagnosis? My diagnosis for this condition is overactive bladder. This is a case of urodynamic overactive bladder. Okay. Does the patient have stress incontinence? No. Okay. Here, this is a table. If we don't have the graph, so look, P det through the pressure. We look here. Oh my God, the pressure here is 59. So the pressure here is 59 and 22. Definitely, we have an overactive bladder. As we said earlier, if we have a 15 figure of 15 or more, then we diagnose overactive bladder. Here we have 22 and 59. Then we come to bladder volumes. First desire 104, early first desire, and maximum capacity 360 and 63, reduced bladder capacity. This is the urethral pressure profile for the same patient. We look only for the maximum closure pressure. Maximum closure pressure. It's 79. Is this normal? Yes, it is normal because the patient age is 54 years old. And we mentioned that around age of 50, the normal maximum closure pressure is more than or equal 60 centimeter water. And here it's 79. So this is normal. So this is normal functioning urethral sphincter. Pressure is 79, as and we mentioned it is normal for this age, normal for age. My comment is here, this is filling cystometry, reduced bladder capacity, early first sensation, bladder capacity as I mentioned 363, this is reduced. First sensation is 104, also early. No leak detected during coughing, patient was coughed repeatedly. No leakage. Unstable detrusor. We have seen that pressure is increased and there is very strong contraction that lasted for more than 1 minute. And the maximum closure pressure is 79. Our diagnosis here is overactive bladder dry. If there is leakage during cystometry, then we may call it overactive bladder wet, but here it's overactive bladder dry type. Another example, 43 years old lady, grabbed the 1 para 1 cesarean section with regular cycles. She presented to the gynecology clinic complaining of leakage of urine during coughing. Clinical examination revealed stress urinary incontinence, and the urodynamic revealed the following. Okay, first desire is 138, approaching 150, and it's around normal. Okay, bladder capacity is 650. As I mentioned earlier, bladder capacity should be between 400 and 480. This is accepted, but we have a wide range. If the patient can accommodate, some females can accommodate up to 1000 cc of urine inside the bladder, but 600 can be accepted, no problem. Above 400 and 480, this is above it. If the patient is having no complaint, just high bladder capacity, it's accepted, no problem. So we have here high bladder capacity and early first desire. Then we look for the leakage. Leakage happened here. First, no. Second trial, no. Okay, and here we have leakage in the third trial. At bladder volume 325, and as I mentioned before, we start testing the bladder for cuff or valsalvatic pump pressure at around 300 cc urine. So here we started at 325. Patient was cuffed repeatedly with very strong coughing and high bladder volume, high bladder pressure. There is no leakage inside the leakage recorded by the machine. Okay, but so we continue the test. If leakage did not happen, we continue the test. Then at bladder volume 450, I think here, yes, patient started to cough repeatedly and leakage happened. So leakage happened at high bladder volume. So at earlier bladder volumes at 325, however strong the coughing or the valsalva, no leakage happens at all. And at 475, when the patient coughed again, then leakage happened during this, at this bladder volume. Okay, about here we have urodynamic stress urinary incontinence diagnosed by cuff leak pump pressure at bladder volume 475. Then we look at the Diffuser curve. This is the Diffuser curve. Okay. Do we have here a contraction, a high amplitude contraction more than 15 centimeter water? No, there is no high amplitude contraction. This appearance of multiple low amplitude contractions, you see here, this is multiple, and it was not associated with desire. So this is normal finding in the cystometry. Okay, so we have here stable Diffuser. Don't have any high Diffuser pressure. Okay, so bladder volume accepted. Leakage happened at bladder volume 475 and stable Diffuser. So we look at the Diffuser here. This is 1, 3, 4, 4, no 15. We have no 15 here, so we don't have any overactive bladder. Bladder volume, first desire 136 and systemic capacity 650. This is cuff leak pump pressure done at bladder volume 325. Leak detected? No, no leakage, so we did not record any figures. At bladder volume 463, patient started to cough again, and leak was detected, yes. Bladder vesicle pressure was 104. So this is type 1 or high urethral hypermobility. But here it happened at high bladder volume, at bladder 463, and the patient accommodates increasing large amount of urine at 650. Okay, so leakage happens when the bladder is near to full. This means that the patient at average bladder capacity at 300 ml, no leak detected, but at 463 cc, the patient leaked, and leaked at very high pressure, 104 centimeter water. This is closure pressure. It is maximum closure pressure is 83 centimeter water. Urethral pressure profile. She is 41 or 44, I remember, years old. So this is normal for her age. Okay, this is a maximum closure pressure, 83. Our comment here, this is pharynx cystometry and urethral pressure profile, normal bladder capacity, early first sensation, no leak detected during coughing, or Valsalva at 325 ml, but when repeated at 463, leakage happened. Normal maximum urethral closure pressure, stable Diffuser. Diagnosis, urodynamic stress urinary incontinence. If you ask it, what's the management of this case? Patient leaks at high bladder volume at 463. So simply tell the patient not to have high bladder volume. Just restrict the patient to have first pelvic floor muscle training, then tell the patient when to evacuate her bladder before reaching maximum capacity. Tell her just to evacuate her bladder every 2 hours, and not let the bladder be full. Not let her bladder to be full. No need for surgery. No need for surgery. Pelvic floor muscle training and regular evacuation of bladder at earlier volumes will cure her condition. 37 years old female, para 4+2, present to the gynecology clinic complaining of leakage of urine during turning over the bed, and that she can't control urine for a few seconds when she has the urge to void, and this was her urodynamic. To be systematic, first we look for the first desire. Here, what is first desire? It's 77 milli or cc. Okay, so our first comment, this is early first desire, should be around 150 as I mentioned earlier, but here it is around 77 cc. Then we looked at symmetric capacity. It's 303. Okay, we have diminished bladder capacity. Early first desire, diminished bladder capacity. Third thing is to look at the Truser curve. Here we have the Truser curve, it's going. Okay, here we have a low amplitude contraction. It's not reaching 15 centimeter water, but it was associated with desire. So this is a diagnosis of an overactive bladder. This is a diagnosis of an overactive bladder. We have single low amplitude contraction where where there was associated with desire. The pressure reached 13 centimeter water, which is more than 5 from baseline. Okay, baseline here is around 4. It's more than 5. Okay, then we look at the base. If there is leakage, yes, there is leakage here. We can see the leakage here. So the patient coughed and it was associated with leakage. Here, look at the Truser. This is 13. If you look just here at the Truser numbers, you will not diagnose overactive bladder because there is no 15. As we mentioned earlier, if you have a reading of 15 centimeter water, this diagnoses overactive bladder, but this is 13, but it was associated with desire. And this is not evident in the this table, okay? Let's see the capacity. The capacity is 303 and the first desire is 77. So from this table, we just can diagnose that we have early first desire and diminished bladder capacity. This is cuff leak point pressure. Patient cuffed, leak was detected. Yes, vesical pressure was 80 centimeter water. So we have what we call mixed urinary incontinence. So our comment is pharynx cystometry, reduced bladder capacity, early first sensation, leak detecting during cuff, low amplitude detrusor contraction, associated with desire without leakage. I mentioned earlier, if this low amplitude contraction was not associated with any desire, ignore it. Okay, this is not an overactive bladder, but it was associated with desire, then this is an overactive bladder. Our diagnosis is mixed urinary incontinence. So if you are asked what to do in this case, first you have to give her a chance for the overactive bladder to be treated, give her anticholinergic, start pelvic muscle training. If the patient condition improved, okay. If not improved, you can go for surgery for the treatment of the stress incontinence, plus giving the anticholinergic for the overactive bladder. Another example, a 41 years old lady, para 5+1, all vaginal deliveries, with regular cycle, presented to the gynecology clinic complaining of leakage of urine since her 4th delivery, 5 years ago. The leakage happens only during attacks of cough or sneezing. She gave history of performing pelvic floor muscle training for the past 1 year that didn't alleviate her complaint. Urodynamic revealed the following. To be systematic, first we look at the first desire, 92. We have early first desire. Then we look to the cystometric capacity, 474, normal cystometric capacity. Early first desire, normal cystometric capacity. Then we look at the Diffuser curve. As we go here, this is 7, no, it's normal. No Diffuser contractions, so we don't have any Diffuser contraction. So this is not an overactive bladder, okay? Then we look down at leakage. Yes, there is leakage. We have leakage here. Okay, so first we have here cuff leak point pressure. We started tell the patient to cuff at bladder volume 250. Patient cuffed many times with high amplitude cuffing, pressure inside the bladder and abdominal cavity with no leakage. Then we repeat it again at bladder volume 450. Patient also cuffed repeatedly. Then leakage happened. But what we see here, we found that the pressure inside the bladder is by negative, it decreased, and the Diffuser pressure also is decreased during this leakage. What does this mean? This area of the graph, what does it mean? It means that the patient, patient is complaining of stress incontinence, and we instruct her to cuff while the catheter is inside her urethra. Sometimes the catheter, urethral catheter, although it is just 6 French, it's a very small catheter. Although it's a small catheter, it sometimes causes bladder outlet obstruction. It obstructs the urethra. So if the patient is complaining of stress incontinence and you tell her to cuff repeatedly, you will not find any leakage because the urethra itself is somehow blocked by the catheter. But if the patient insists that she's having stress incontinence, you simply remove the catheter from inside the bladder and let the patient cuff. And instead of measuring the pressure and taking the Valsalva leak point pressure as the vesical pressure when the patient leaked, you can take the abdominal pressure. So you can use the abdominal pressure instead of the vesical pressure for calculation of the cuff leak point pressure. Okay, so this means that this patient is having stress incontinence, and it is mild because the patient is leaking at very high bladder, or not very high, a high bladder volume is around 450. It should be around 300. The second thing is that in spite of coughing repeatedly with the catheter inside, she did not leak, but we had to remove the catheter in order to demonstrate this leakage. So it is a mild form of stress urinary incontinence. Here, as we can see, first desire to void is around 92 ml, early first desire. Cystometric capacity, normal cystometric capacity 474, more than 400. Diffuser pressure 0774, not elevated at any time. Normal stable bladder. Okay, this is a cystometry with early first desire to void. Normal bladder capacity with stable diffuser. Patient didn't leak at bladder volume 250 and at 450. She leaked during coughing after removal of the transurethral catheter. Her abdominal leak point pressure was 115. This means that the pressure inside the abdominal cavity must exceed 115 centimeter water for patient to leak urine, which means that she has a very strong cough or repeated coughing or vigorous exercise for leakage. So this is a case of urodynamic stress urinary incontinence with pure urethral hypermobility. My opinion, this patient will benefit from pelvic floor muscle training, and she will have very much marked improvement on this pelvic floor muscle training. Another case, 28 years old female, para 3 SVD, with history of instrumental delivery during her last delivery 2 years ago, presented to the gynecology clinic complaining of leakage of urine associated with walking or performing daily household and sexual intercourse, and she also complained of urgency and frequency. Urodynamic revealed the following. Again, here we're looking at first desire, it's 79, okay. Cystometric capacity 337, يبقى early first desire, diminished bladder capacity. Then we look here for the Diffuser curve. We go, nothing. It's not elevated, but here at the end, you see it's how much? It's 15. This is what we call a terminal detrusor rise. With detrusor pressure, either terminal detrusor rise, as we mentioned in the at the beginning of the lecture, or we have contraction, then relaxation. A contraction of the detrusor, then relaxation. Here you don't have any contraction, stable, but at the end of the test, there is terminal rise up to 15 centimeter water. So we have an overactive bladder. Then we look at the VLPP, valsalva leak point pressure. Here, we told the patient to push, then leak happened. Here, while we were testing the transmission of the both catheters, it's a test we do during urodynamic. We tell the patient to cuff to see if the both catheters, the abdominal and the vesical catheter, are transmitting pressure equally. Patient leaked. So we started performing a valsalva leak point pressure at bladder volume 225, and we found that the leak point pressure here is 73 centimeter water. Is very evident here. So here, look at the detrusor pressure. We have terminal detrusor rise around 15 centimeter water. This is the diagnosis of overactive bladder. Bladder in volumes, we have first desire, early first desire, it's 79 cc, and systolic capacity maximum 337. So diminished bladder capacity also. This is the valsalva leak point pressure. Patient detected yes. Vesical pressure during leakage was 73 centimeter water. So this is a case of mixed urinary incontinence. Early first desire, reduced bladder capacity, elevated terminal detrusor pressure, leakage during valsalva with stable bladder, leak point pressure 73 centimeter water. So this is a mixed urinary incontinence. What's your plan of management? Give anticholinergic, pelvic floor muscle training. If no improvement, then we can proceed for surgery. Okay. Although here is the leak point pressure indicates that it's type 2 by Maguire classification, most probably this patient will need surgery. Plus anticholinergic or beta 3 agonist. Another example, 27 years old female, normally gravida, presented to the gynecology clinic complaining of urinary incontinence. Detailed history revealed that the incontinence episode happens only during orgasm. Urine analysis and culture were negative for infection. Pelvic ultrasound, no abnormality. Urodynamic revealed the following. Okay, first sensation here is around 110. Okay, so early first sensation, we'll go systematic, see first sensation. Then we have bladder capacity 423, average or normal bladder capacity. There is no leakage at the base. It gives a black mark at the base if there is leakage. Then look at the detrusor curve. It's going. Then approaching the full bladder capacity, the pressure increased up to, I think here scale is 20, and more than 20, about 30 centimeter water, and stayed for a long duration. So this is a persistent terminal detrusor contraction. So from this graph, we can diagnose an overactive bladder. Okay, here this is the volumes. Early first desire 114, bladder capacity normal 423, and the detrusor pressure is recorded once a strong 17 centimeter water, then at maximum systolic capacity 21. So it is more than 15, then this is a overactive bladder, an overactive bladder. Normal capacity, early first sensation, strong detrusor contraction, started at bladder volume 115, detected during cuff, diagnosis overactive bladder. Management, anticholinergic or beta 3 agonist. Another example, 32 years old female, null gravida, present in the gynecology clinic complaining of frequency and urinary incontinence, revealed that incontinence happens only during orgasm. Urine analysis and culture are negative for infection, and urodynamic revealed the following. Here we are all start here. First desire is 133. Normally around 150. We can say it's early. Okay. bladder capacity 497, normal bladder capacity. Okay, then look at the base, no black mark or black dot. This means that the patient did not leak during the test, whatever during coughing or without coughing. Then at the end, we look at the Diffuser curve. It goes smoothly. It's near the baseline. Okay. And this is not a contraction. This is from coughing. It's some sort of artifact. This artifact also. Then at the end, the Diffuser pressure is 4. So we don't have any finding except the early first desire, and it's not so much early. It's around 150. So this is a normal urodynamic study. Apart from this figure, early desire, everything is normal. Normal cystometry. Here, what is this? This is a uroflowmetry. Okay, this is uroflowmetry. This is the shape of uroflowmetry. It's like that. It's bell-shaped like that. And this is the maximum flow rate. It's 41.3. It's very normal. Voided volume is 522. Remember that for the test to be valid, this number should be more than 200, and the maximum flow rate should be more than 20. This is maximum flow rate for 41 normal. Okay, it's more than 20. Residual volume 5 normal. Okay, then another curve. We here see that there is a very strong contraction. A voided volume is 339 with maximum flow rate 67.3, very high maximum flow rate. More than 50, we call them super voider. This patient most probably is having some sort of overactive bladder, and she cannot hold her urine inside. When she started to emptied with high pressure due to strong contraction of the trusor muscle, ending in high maximum flow rate. And this is some females post void dribbling. Okay, maximum flow is 62.3, very high. As I mentioned, super voider. Residual volume 25. This is normal. It should be less than 50. It's accepted. 25 is accepted. No problem. Okay. This is also uroflowmetry. We found here that the patient is voiding. This is not a bell-shaped curve. Okay, it's prolonged voiding with maximum flow rate 12.1, void volume 324. Okay, this is valid test. It's more than 200, but we have very long duration. This is first number one. Number two, reduced maximum flow rate. This patient is having some sort of bladder outlet obstruction, whatever the cause. Okay, so this is a picture of bladder outlet obstruction. Not complete obstruction with retention, no. But this patient is voiding with difficulty and on a longer duration. What is the cause? Whatever the cause is, post-operative, she has prolapse, whatever. But this patient is having her bladder outlet is not functioning as it should be. Then again, this is a cystometry. We look at the first desire, 150 normal, bladder capacity 467 normal. Okay, Diffuser, very smooth curve, no elevation. You have a stable bladder. Then look at the base, there is leakage. Yes, this is the leakage. It happened at the end of the test at maximum cystometric capacity. Valsalmatic pressure was done here. Patient pushed down and coughed many times, no leakage. But at full bladder capacity, patient leaked. So this is a urodynamic stress incontinence, and as previous examples, it's a mild form, so patient can benefit from pelvic floor muscle training. This is a Valsalva leak point pressure. This is just a part of the graph. Here we tell the patient to push or to or to cough repeatedly until leakage happened. Here leakage happened at this is the leakage, okay, with a stable detrusor. Okay, so this is a Valsalva leak point pressure demonstrating urodynamic stress urinary incontinence. Then another curve. Systematically, first desire is 45. This is markedly or reduced or very early bladder desire. First desire, it's around 45, and it has a very strong detrusor contraction. The first desire was around 30 cc, and the detrusor pressure was 45. This is very strong detrusor contraction. And we have, as we see here, multiple detrusor contraction, multiple high amplitude. One of them reached more than 60 centimeter water. Okay, and here we have bladder capacity diminished 251, and Valsalva leak point pressure, no leakage happened here, but I think it is with the detrusor contraction, so we cannot thoroughly evaluate the stress incontinence with these contractions. This patient needs to have anticholinergic and her bladder to calm down first, then re-evaluate the patient for stress incontinence, because sometimes we have what we called stress-induced detrusor contraction. This contraction might cause leakage. We have leakage here. Then another one, first desire is 185, good. Bladder capacity 419, stable bladder. Then we look for the detrusor curve. It goes on, goes on. Here patient coughed and there is leakage. We have stress incontinence. Then this area, patient was still coughing and the catheter went out. We found that the pressure is by negative. This means that the catheter is out. Then patient catheter was reintroduced and we continued the test until full bladder capacity. Okay, so what we have here, we have stable detrusor, normal first desire, normal bladder capacity with urodynamic stress urinary incontinence. How to diagnose it? By Valsalva leak point pressure, there was leakage with coughing or Valsalva. Normal capacity, intact sensation, stable detrusor, leak detecting during cough without contraction. Lowest recorded vesical pressure during leakage was 47 centimeter water. This is urodynamic stress incontinence, and this is an ISD, intrinsic sphincteric deficiency. Why? Because leak point pressure is less than 47 centimeter water. You remember Maguire, type 1, type 2, type 3. Type 1 leak point pressure more than 90, type 2 between 60 and 90, and type 3 less than 60. This is less than 60, so this is an ISD. What you are going to do for this lady? This lady definitely needs surgery. She will not benefit from pelvic floor muscle training, and her best option is tension-free vaginal tape retropubic approach. When we have multiple leakage during coughing with Valsalva leak point pressure, we take the lowest recorded pressure, which is 47 centimeter water. Thank you, and I hope that you benefit from this lecture.